On behalf of the Interoperable Health Worker Education Management System Concept Note team, thank you for this opportunity to present this overview. During the Ebola response, multiple organizations trained many health workers in how to protect themselves and provide clinical care. Stakeholders conducting these trainings captured training data in separate, siloed paper and electronic tools. However, this information about who was trained, what they were trained in, and the facility where they work was often not systematically recorded, stored, and shared with the ministries by these implementers. If an Ebola or similar epidemic strikes again, it will be difficult to identify who the trained health workers are, who may need refresher trainings, and where the workers are located. It could delay the outbreak response and ultimately put lives at risk. What can be done to coordinate the collection and integration of sources of health worker training information to have more accurate information to deploy appropriate trained health workers to locations in most need of their skills, and determine which health workers should be targeted for further training? To achieve this goal, the intervention has 4 objectives. First, it will foster a community of practice to develop clear guidelines, standard operating procedures, and a policy framework. As part of the community, there will need to be agreement on the data exchange standards to exchange the information. We will achieve regional and global consensus on those data exchange standards. With the consensus in place, in year 1 of the program, we will add functionality to existing deployed components to achieve interoperability through identified systems that exist in Guinea and Liberia. In years 2 and 3, we plan to expand the intervention to Uganda and South Africa systems. Throughout the process, we will provide data use and analysis assistance training on using the integrated data for HRH interventions. In the target countries of Guinea and Liberia, we already have several of the openhie components deployed as part of MHERO. This includes the Interlinked Health Worker Registry, which is pulling health worker information from IRIS and other health worker information systems. There are also training information systems. The first technical objective is to link the training information system to the health worker registry, synchronizing a minimum data set of health worker demographic data using the CSD standard. Once this has been accomplished, we will identify standards for uploading information about the courses attended, continuing education units and continuing professional development credits, and competencies obtained. Once the training information is available centrally, Ministry of Health staff, as well as implementing partners, can ensure health workers are receiving appropriate trainings. Additionally, this data can be mined for automatic indicator reporting, such as PEPFAR's H2.2.D, on, quote, number of community health and parasocial workers who successfully completed a pre-service training program. In Phase 3 of the project, we will integrate learning management systems with the health worker registry, again using identified standards. These can be web-based applications, such as Moodle, as well as various mobile-based platforms. We will leverage existing training content to integrate within the learning management systems. We will also synchronize the health worker training information with the health worker registry, as we had done with the training information systems. Building off the previous work, we will leverage the large deployment footprint of IRIS in sub-Saharan African countries, including most of the countries affected by Ebola. Here we will add user interfaces to IRIS to allow training managers at central and local levels to initiate trainings using the learning management systems. The user interface will build off the existing familiar MHERO interface and allow the training managers to select cohorts of health workers by various filters, such as cadre, geographic location, competencies obtained, and date of last training. In addition to the tangible ICT deliverables, we will have clear, measurable outcomes. Examples of impacts include the ability for policymakers, training institutions, professional councils, and others to make informed decisions about the training, refresher trainings, and knowledge reinforcement needs of individual health workers and cohorts of health workers. Key stakeholders will be able to make informed decisions about which health workers should be deployed where, in times of urgent health response needs. Intentional training linked to accessible resources via learning management systems can support ongoing quality skills and performance, leading to quality improvements in service delivery. Looking beyond the project, we are building towards greater interoperability of components of the health information system. The first is a linkage to health management information systems such as DHIS2. We have already discussed the ability to report training indicators to DHIS2. As a future direction, we monitor information captured in DHIS2 and set automatic triggers based on thresholds for disease incidence. For example, an outbreak of cholera in a district could trigger a query against the health worker registry to determine all the community health workers in a district. Then, we could initiate an SMS-based learning refresher on care protocols delivered through a learning management system. In another future direction, we look past population health and monitor clinical encounters captured in point-of-care applications. We could then initiate just-in-time training for a health worker based on their clinical interactions and the competencies they possess. This concludes our presentation. Once again, thank you for reviewing our concept note. We're happy to answer any questions you may have.